Hello, my name is Duk-Woo Park in Ulsan Medical Center, and thank you for joining this year APCIS meeting. And my topic is about the state of art left main coronary artery stenting, about the updated evidence and unmet need. This is my disclosure. So, if you're gonna think about the current available treatment option for a left main coronary artery disease, we consider two invasive and less invasive option. Is a gold standard was the coronary bypass surgery that was invasive treatment. The counterpart, another one is a less invasive strategy. Left main the stenting is the percutaneous coronary intervention. Two different strategies are now available for treatment of a significant left main disease. So, if you think about the revascularization method and mechanism, and this review article is described well underlying mechanism about the coronary artery disease, bypass surgery as well as PCI. So, this diagram shows the intuitive description of how treatment is work. And if you're gonna put the stenting, stent is a pro-limiting region was treated. However, in the another limitation, non-flow limiting region is the less severe obstructive region. However, we could be vulnerable part cannot totally controlled. If you're gonna bypass graft in the distal part and the proximal part, there was some happening of a flow limiting region rupture or not flow limiting plug rupture. If bypass surgery can prevent the future event, there was the underlying mechanism of the difference bypass surgery and the PCI. So, bypass, the coronary myocardial revascularization, there are three different treatment mechanism. Major one is coronary flow capability restoring. There was a relief of coronary obstruction. Also reperfusion. Also future impact prevention. PCI is work restoring coronary flow capability and the reperfusion. However, PCI cannot prevent absolutely the impact prevention in the future. Bypass surgery in the looking at the underlying mechanism can prevent the restoring the coronary flow capability and the reperfusion and impact prevention. That some difference of the underlying mechanism, bypass surgery showing the better long-term durability. So if you're gonna reduction new and the non-lethal myocardial infarction, future MI the event, you can achieve the mortality reduction. There was a nearly linear association. Also, another meta-analysis shows that if you're gonna treat MI reduction in the future during long-term follow-up, you can achieve the mortality reduction. So, a recent review paper described the long history of the PCI versus bypass surgery for treatment of multivascular disease and left main disease, and a well-written paper. This is done by Patrick Saray. Counterpart paper, this is done by the surgeons groups, Michael Mack and Dr. Preeti Moe, and describe the last 50 years bypass surgery advancements. This is two article, is a very well written paper. So we consider left main treatment at the nearly half of a century ago. Bypass surgery was absolutely gold standard. Now it's still gold standard. This guideline is one. Treatment effects are excellent. PCI is balloon angioplasty just available nearly 50 years ago. Nowadays, PCI is much improved with the advancement of drug-eluting stent and the stent technique and adjunctive pharmacology. Treatment gap has narrowed over time. So, and the updated evidence showing the left main disease PCI versus bypass surgery, low and intermediate risk anatomical complexity, drug-eluting stent, bypass surgery showed the similar mortality and similar composite outcome. PCI was associated high-risk repeat revascularization. By contrast, the low-risk stroke compared to bypass surgery. However, still long-term durability still issue. Also, there are some controversial issue, and the anatomic group is left main plus 1 vessel, 2 vessel, 3 vessel, and the ostial region versus distal left main bifurcation region. According to heterogeneity of anatomic group, PCI recommendation, KBG recommendation could differ. Also, some data conflicting. Is registry data, RCT data shows conflicting result. Also, length of follow-up, some data available 5-year follow-up, some clinical trial is available 10-year follow-up. Also, best endpoint still is the highly debated MI and repeat revascularization, quality of life, and something like that. Also, rate catch-up event. And the last issue is complete versus incomplete revascularization concept, still highly debated. And some data, our main compare registry, Excel, Noble trial over the time, beyond the 5 year, there was some trend and the signal favoring bypass surgery over PCI. So, and the Excel really last 3 and 4 year highly debated after report the 5 year result of the Excel trial, and the Excel investigator, and there are some many debated between cardiac surgeon and the interventionist. And the Excel trial, there is available largest clinical trial comparing drug-eluting stent versus bypass surgery, showing the all-cause mortality, hard endpoint, the death, MI, stroke, and beyond 3 years, there is some catch-up and crossover. Also, one of the issue, all-cause mortality, there was one of a very hard clinical endpoint is a favor bypass surgery over PCI. There was statistically significant after release of a 5-year Excel trial debate and still continue. And the mortality difference, this is still controversial. And the Noble trial, the 5-year outcome, absolutely no difference, all-cause mortality. And the Syntax trial up to 10 years, there is no difference of mortality. That was the same, our pre-combat trial up to 10 years, absolutely no difference, PCI versus bypass surgery. Also updated meta-analysis, AMED, there was published European Heart Journal, risk reduction was nearly no difference mortality. There was a left main confined meta-analysis. If you include multivascular disease and the Stuart head, and the Dr. Mario Gaudino meta-analysis included multivascular disease, beyond the left main disease, there was a favor bypass surgery than the PCI with respect to all-cause mortality. MI, and there was still debatable issue, and according to different definition of the MI, there was a overall instance is definitely different, and some definition is PCI higher, some definition PCI is lower. There was the vice versa was present. Also, even in Syntax trial, if you apply the different definition, overall instance of MI is absolutely different. Syntax trial, Syntax definition comparable, force universal definition comparable, ischemia definition, PCI is lower, and the SKY definition is the PCI substantially lower. There was how much different is overall instance of the MI definition is according to different definition of MI definition. So, and the Excel trial was the same. Protocol definition, bypass surgery was higher. If you apply the third universal definition, PCI was higher. This is the opposite trend. Also, mortality impact was a difference. There was a still debatable issue. The reason why many clinical trial scientists is debate is time to remove procedural MI from primary composite endpoint in the future clinical trial. It cannot find is a universal definition. That is still debate continue. And what are next step? Left main PCI versus bypass surgery. And recently we did individual patient the meta-analysis that was done, Harvard group, TIMI group, and including Excel trial, Noble trial, Syntax trial, pre-combat trial, is a individual patient data was collected, and this trial was finally accepted. The Lancet journal will be presented late-breaking trial and this week, and AHA late-breaking trial. This is finally accepted in the Lancet journal. Also, and if you think about the PCI arm, there are still many portions in the state-of-art PCI. What make a complex PCI could be equivalent to bypass surgery. There are many concepts and imaging concept, plus a functional concept. Although phase 3 trial did fail to achieve the primary clinical trial endpoint, PCI was inferior to bypass surgery. Still, if you combine the imaging concept, FFR concept, also complete and the incomplete revascularization concept, we can definitely more better outcome with PCI for left main disease. Surgery is also improved, and so in the future, RCT might be not available in the future, but several registry study would be available to compare for left main disease. So what is known and what is unknown? So what is known? PCI versus KBG, comparable risk and mortality, hard clinical endpoint. We know well advantage of bypass surgery, long-term durability, less spontaneous MI, is PCI, less invasive, early mental and physical recovery, and the low risk of short-term morbidity. And what is unknown still, and the PCI versus KBG, and the long-term treatment effect of KBG versus state-of-the-art PCI combined imaging and the functional concept, still we don't know. Also, in specific population like diabetic and HAP-REP and the distal left main bifurcation region, we require more data. And the threshold for regional incomplete revascularization is we still don't know. And the left main PCI and the optimal stent strategy for distal left main bifurcation disease still should be further defined. Optimal antithrombotic strategy following complex PCI, especially in East Asian population, should be further debated. This is my last slide, and updated long-term evidence showed the PCI with the drug-eluting stent and bypass surgery were comparable with respect to serious composite outcome and all-cause mortality for left main disease. PCI and bypass surgery are different interventions, are performed in different patients with different aims. Surgery is associated with higher peri-procedural risk and discomfort and better long-term clinical outcome. PCI assure outcome comparable to surgery with much lower invasiveness. The two interventions are complementary, not antagonist. Thank you for your attention.